Okay, good morning. My name is Sabah Basanthi. Welcome to your second webinar from the clinical team. I know this is not your second, but this will be your second from us, the clinical team. My disclaimer, this is not an all-inclusive PowerPoint. For detailed coverage and limitations information, please refer to the links to all the handbooks we've provided for you at the end of this presentation. Now, I did not provide the link for the fee schedule, but I believe the fee schedule is on the ACA website. So if you click the link for the Medicaid handbook, you should be able to get to the fee schedule. And if you can't and need help, you can email Elizabeth and we will try and help you with that. This is a short overview to offer guidance. Like I said earlier, for detailed information, please use your handbooks at all times to gather additional information. This webinar will cover CMS, Consumable Medical Supplies, and DME, Durable Medical Equipment, Medicaid state plan requirements for those items, as well as Medicare coverage for CMS and DME, and our lovely iBudget waiver handbook requirements for CMS and DME. We will also talk a little bit about something we talked about previously, which is transitioning from Medicaid to waiver. DME, what is it? DME is an item that can withstand repeated use. You use it, it's used by the client to serve a medical purpose, and it's really not useful to anybody without any illness or injury, and it is appropriate for use in the client's home. Now, all of the information in here did not come from me personally, they're all from the handbooks. You hear a lot about medical necessity. Medicaid service criteria for DME states that it needs to be medically necessary, appropriate for the client, in the intended medical use, and exclusively for that client and nobody else. The same goes for consumable medical supplies. Consumable medical supplies have to be, once again, medically necessary. They're consumable, you use them a couple of times or maybe once and you're done with them. They're disposable and, again, appropriate for use in the client's home. Medicaid service criteria for consumable medical supplies, again, have to be medically necessary, and the medical necessity documentation that's submitted must specify the type, quantity, frequency for the supplies as prescribed by the client's physician or healthcare providers. Sorry, I got carried away, it's a duplicate. Waiver, as far as consumable medical supplies, waiver criteria for supplies, we basically cannot cover any item that's covered by Medicaid state plan. I'm sure you've all heard of waiver is the payer of last resort. So we won't cover any item that's covered by Medicaid state plan or another insurance provider. And as with everybody else, it has to meet the definition of medical necessity. Every case that comes to state office or your regional office, whether it's an annual review of services for the client or a stand request, has to be reviewed for medical necessity, regardless of how long the client has been receiving the item or the service. And the purpose of medical necessity is to determine if the service, level of service, is still needed, is still necessary for the client, and consistent with the definition of the service in the handbook. This right here that you see on the screen is the criteria for medical necessity. We follow this as we review each and every case that comes here. It's found on page 1-8 of the Medicaid handbook, and I'm sorry, page 1-8 of the iBudget handbook, and in the Medicaid handbook is found on page 2-9. I would suggest you print this, keep it with you, memorize it if you want, but refer to it because we do refer to it for every case that comes in. DME and CMS medical necessity has to be necessary to protect life, prevent illness or disability, or to alleviate severe pain. It must be individualized, specific, and consistent with symptoms or confirmed diagnosis. I'll tell you a story, short one. I asked my doctor or my kid's doctor for an order for some lab work. I took my son to get the lab work done, didn't look at the request or anything. Long story short, I got slapped with a bill for a couple of things that were not medically necessary because my son did not present with symptoms that warranted the request for that for the lab, but my doctor prescribed it because I asked for it. And now I have to pay for it because my insurance company will not pay for it. So again, it has to be individualized, specific, and consistent with symptoms or confirmed diagnosis of the illness or injury that is under treatment and not in excess of the client's needs. Medical necessity continues. It has to be consistent with generally accepted professional medical standards and not experimental or investigational, as determined by Medicaid program. We continue on with medical necessity must be reflective of the level of service that can be safely furnished and for which no equally effective and more conservative or less costly treatment is available statewide. And what that means is it has to be rendered in the most cost-effective manner, efficient but cost-effective. Be furnished in a manner that's not intended for the convenience of the client, the caretaker, or the provider. And this is the one that gets everybody stumped. The fact that a provider, meaning healthcare provider, has prescribed, recommended, or approved the service does not in itself make the service medically necessary or a medical necessity or a covered service. We all know, or maybe some of you know, most families can get their doctors to write an order for them. Does it mean that the service is necessary? I'm not sure. We have to look at the case and determine medical necessity and make a decision on whether to approve or partially approve the service. No state has a definition of medical necessity that says a treatment is medically necessary because a doctor has prescribed it. All states have other restrictions built into their definitions of medical necessity, and many states have cost restrictions built in their definition in an effort to reduce their cost. For example, Florida limits patients to the least expensive treatment that is effective. And other restrictions require that the treatment provide a significant benefit to the client and that the treatment is not provided primarily for the patient's or a doctor's convenience or family's convenience. Who pays for what? G-tubes, pumps, gauze, tape, suction catheters, ventilators, trach tubes, formulas, wheelchairs, REMS, Q-tips. My goodness, the list goes on and on. But who pays for what? You can refer to the handbook for detailed information and to get an understanding of the required documentation that we need to approve services and supplies that come to state office for review. Medicaid requirements for DME and CMS. Medicaid will reimburse for a service that is not a duplicate of another provider's service, and again, are determined to be medically necessary. And the documentation for medical necessity, again, has to include the type of equipment, services, or supplies ordered, including quantity, frequency, and length of need as ordered by the physician of the client. Now, medical necessity, Medicaid reimbursement. Medical necessity must be established for each service and documented at a minimum with the following: a written prescription that's now more than 12 months old. I'm sure you've all gotten RAIs from us requesting for prescriptions for services and or supplies that you are requesting for your clients. We can also use, or Medicaid will use, a hospital discharge plan or certificate of medical necessity, a plan of care if it's a home health agency. And as stated earlier, all documentation of medical necessity has to include the type of equipment, services, or supplies that's ordered.
Okay, this is just a reminder with regard to, we're not going to spend a lot of time on Medicare, but this is a reminder that waiver is payer of last resort, and we do have individuals that some have insurance, some have Medicare, and that we need to do our due diligence to make sure that we look at these. Medicare has their own rules, which are different than Medicaid rules. Individuals may have Part A, they may have Part B, they may have Part A and B. So just a brief overview with regard to, if an individual has Medicare Part A, DME is covered in some cases, but it's very specific to whether or not that individual is either hospitalized or eligible for home care. So if they require medical supplies based upon an injury or an illness while they're either hospitalized, then they are covered under Medicare Part A. Part B, which is original Medicare, may cover some medical services and supplies that are medically necessary to treat their health condition. So this includes outpatient care, preventative services, ambulance services, and DME. Medicare has different criteria with regard to how you qualify for coverage. Again, it must be durable, which means it's got to withstand repeated use. It has to be used for a medical reason in the home. The benefit has to be in the home. If you go out of the home, that's okay, but the benefit is in the home. And it must be an item that is generally not useful to someone who isn't injured or ill. So some of the common Medicare items that are covered, hospital beds, walkers, commodes, wheelchairs, nebulizers, oxygen, sleep apnea devices, infusion pumps, diabetic supplies, some incontinence products, and orthotics and braces. So for the most part, Medicaid generally pays for the basic model of the DME equipment. Upgrades are usually the responsibility of the recipient. The DME has to be useful, and it's got to be, again, the benefit has to be used inside the home. Modifications to living quarters are not covered, and Medicare often does not cover single-use items unless the recipient is receiving home health care. One other thing I just want to mention with regard to Medicare, which is actually, it's pretty big because Medicare has an 80-20 rule. Medicare generally pays 80%. The recipient is responsible for the other 20%. So that's something that actually needs to be kept in mind. The other thing I believe that we did with regard to Medicare is we provided you a link for, there's a very good CMS booklet that is specific to Medicare coverage of DME and other devices. So that link should be at the end of the presentation.
Yeah. Okay, back to waiver. Waiver reimbursement requirement for CMS. You all know this. Services must not be authorized via waiver if it's available from another source. And as WSCs for your clients, you have a very important job to do to ensure that you are checking other funding sources and providing documentation that you have done so. And other funding sources are natural or community supports, third-party payer, could be private insurance, Medicare, and other Medicaid programs such as Medicaid state plan or managed care. According to waiver and the handbook, all equipment must have a direct medical or remedial benefit to the recipient, be necessary to prevent the clients from being institutionalized. And we do require an assessment and prescription for DMEs. We talked about this on our previous webinar, so we're just gonna touch on it a little bit regarding aging out from state plan services to waiver at age 21. What happens 6 months prior to the client turning 21 as it relates to CMS and DME? Okay, transitioning to APD waiver services. The different plans, Medicaid state plan or whatever insurance provider the client has in EQ Solutions prepare for the transition. Transition planning typically happens every 3 months if the client is in a nursing facility. And DME and CMS items should be included in the discussion for transition planning. And that will include what Medicaid will continue to pay for when the client transitions, because there are still some things that Medicaid will cover even after the client turns 21. And there are some items that will stop under Medicaid, and waiver will pick up the cost of some of those items. And you can find the information as far as what Medicaid will pay for on the fee schedule. This is just no timeline. 6 months prior to the consumer's 21st birthday, best practice for transition, you begin the process to identify the consumer's current needs, and 3 months prior to turning 21, although that's not always the case, we get calls at 5 p.m. on the 21st birthday or when the client turns 21 or the day before from EQ asking about the client's status. So 6 months prior, you start planning, and 3 months prior, best practice recommendation is for you to update your support plan. Hopefully you are included in the meeting, the transition meeting. Once you are aware that the client is going to be turning 21. So you gather all your information, update your documents, gather all the documentation that you're going to need to include prescriptions, plan of care, but all of that depends on the client's services and supplies that they will need upon aging out. And you will then submit the information to APD at the 3-month mark, and hopefully before or by the 21st birthday, everything will be set for the client when he or she transitions. I want to talk a little bit about general character items because we do see a lot of that. A prescription submitted for supplies like diet products, over-the-counter medications, vitamins, herbs, which has general utility or is generally available to the general population without a prescription, does not change the character of that item for the purpose of coverage under the waiver. Items like deodorant, lotions, cream rinses, creams, ointments are not covered by the waiver regardless of whether it was prescribed by the physician. I've had cases and phone calls where I've been told, well, waiver has been paying for it all along. Why are you saying now it's not covered? I don't know why waiver has been paying for it all along, but I can tell you, just because it was prescribed by the physician doesn't make it a covered item. We do not cover peri-rinses, creams, lotions. It's like paying for shower gel for a client, and waiver does not cover that. Excess or overages versus waiver. One thing to remember, and I'm sure you've heard this, waiver is a payer of last resort. Waiver is not going to pay for extra items that Medicaid is already paying for. Now, if the item is truly medically necessary, I believe there is an exception process that the client can go through to see if Medicaid will pick up the excess. There is one exception to this. Waiver funds cannot be used to purchase additional quantities of consumable medical supplies that are above the Medicaid state plan limitation amount, except it is determined that the recipient's health cannot be met within the limits of incontinence supplies set by Medicaid state plan. And as far as incontinence supplies, based on the exception that I just read in terms of excess, to request an exception for additional incontinence supplies, a doctor or the client's doctor, healthcare provider must prescribe or provide a statement of why the items are medically necessary for the recipient's health and how those items are directly related to the recipient's developmental disability. And the regional medical case manager must concur before the additional items can be approved. And this information is found in the iBudget Waiver Handbook, page 2-28 or actual 66. Welcome to Suelyn and Duke. We're going to talk about two clients. Suelyn is aging out of Medicaid state plan. She has a tracheostomy and a G tube. She's incontinent of bowel and bladder and has been receiving the items below from Medicaid state plan. Tracheostomy supplies to include ties, collar, and inner cannula, suction canister and suction catheters, sterile water, diapers, wipes, bed pads, formula for her G tube, feeding pump, pole, bags, and extensions. Suelyn, when she ages out, will continue to receive from Medicaid state plan her tracheostomy supplies and everything that goes along with her tracheostomy supplies. Suction canister and suction catheters and the formula for her feedings. What will she get from waiver? Let's see. APD waiver, when she ages out, will pay for diapers, wipes, bed pads, the pump, the feeding pump, the IV pole, feeding bags, and sterile water. 500 mLs or more. Duke, he's 35 and has been on the APD waiver for years. He received a colostomy and a G tube 2 years ago. He's due for an annual support plan review and has been receiving the items below from the waiver forever and a day. Colostomy supplies, G-tube extensions, diapers, wipes, pads, feeding bags, pump and pole. And his packet is now here for review. Upon review, and at the end of the review, the determination will be that Duke will continue to receive diapers, wipes, pads, his feeding bags, pump, and pole from APD. The rest that APD has been paying for, unfortunately, will need to go through Medicaid state plan. And those are the colostomy supplies and the G-tube extensions. Let's talk about some SAN screen best practice. When a reviewer is in front of his or her computer, we get into a zone. I'll talk about myself. I'll get into a zone. I'm on a roll. I'm reviewing everything. I've reviewed the documentation and I'm getting ready to make a determination on the supplies, and I get to the SAN screen and this is what I see. Procedure service code is up there, service rate $357. I have no quote, I have no idea what the cost of each of these items are. But in the description box, this is what's written in the description box: 6 packs of wipes, 4 feeding sets, 30 syringes, 20 sponges, 200 gauze, washable bed pads. Now I have to stop, dig through the folder some more to see if I can find a quote that will at least tell me the cost of each of these items. It's really complicated, or it takes time away from the review process when the reviewer has to stop and decipher the information that's written in the comment box for this client. So it's very important that if you're going to lump items together, that in the description box you include not just the item, but the cost of each item. And the reason for that is if there are certain items that need to come from Medicaid state plan, it'll be easy for the reviewer to end this screen, create new screens with the items that are reimbursable under waiver. But we're not having a quote or a description of the cost of each item in the comment box. We have to stop and most likely do a request for additional information, delay the review process further. So the recommendation here, I'm not saying do not lump, but if you're going to lump items together, we Best practice recommendation is for you to be as descriptive as you can be in the comment box by itemizing the items, the quantity, and the cost of each item. And also, it's helpful to get a quote from the supplier. Sometimes the quotes aren't even helpful, but there are some quotes that are really helpful. The quotes will list the item, how many, like for wipes, how many wipes are in each packs, how many packs comes in a case, and the cost of each case. So it's important that as you gather your documents to present, that you have a quote, and if you're going to create, if and when you create the SAN service screens, that you try to be as descriptive as you can if you are going to lump some things. Now, some things just shouldn't be lumped together. I believe bed pads have their own code. So it's refer to the fee schedule for the code and create. It may seem like a lot of work, but it makes the review go quicker. And the reviewer wouldn't have to stop and dig for information, call you or email you or do a request for additional information. So this screen is not the best screen at all. Now, take a look at this. Isn't it lovely? Look at the description. 6 packs of wipe per month, $7.50 each at $45 monthly. There's a description of the item and the cost of each item and the monthly cost of each item. So if something here needed to be removed, it will be a lot easier to create another screen. And I now understand as the reviewer the annualized amount of $4,284, what that's all about, what is being paid for with this amount of money. So once again, as you do your SAN screens, I've seen screens and the description says items needed to maintain health and safety of the client. Well, that's great, but that doesn't tell me anything about what's covered under that service rate and what all this money is paying for this client. You want to say anything else? Okay, these are the links for the handbook, the iBudget handbook, the Medicaid handbook, and the handout that Lori talked about earlier from Medicare. The fee schedule is not here, but I believe when you go to this second link, you should be able to find an option for the fee schedule.
If not, we can include it.
And if not, we can send it to Elizabeth and she can send it to you guys to refer to. That's it.
Okay, so I'm going to leave the links up here for you, and just so you're aware, while it's presented on the call, you can't actually click it. It's a static link, but if you access the links through the PDF that's on the attachment or on the website, you can click them there. So there's easier ways to get to it rather than writing it down and typing it into your browser. But I will leave it up just so you guys can see it. And as we go through the questions that have come in, if there's some moments where it gets quiet, it's just because we are reading through and coming up with answers. So just bear with us if we have some silent moments, but we are going to start to go through these that have come in, and as we continue, we have plenty of time. So the conversation is still open. Think about, everything that Sabah has gone through. If you have questions, if you have comments, just go ahead and send them to us. This is your best platform to get messages to us in a live manner. Petra, we are looking at your question. You asked who generally does the assessment. Can you send us another message and just clarify that question, please? What assessment are you referring to?
Go. Regarding the question about the hospital bed, we unfortunately would not have that information. We encourage you to use the link to Medicaid Complaint Hub and get them to help you find providers that can provide the hospital bed that you need. This is the process for regional medical occurrence with additional supplies. Okay, so we have a question that says, at one time we were told we needed to list items quarterly and monthly on the service authorization. Is this still true? You can do either one as long as what you are authorizing is very clear. So that's why the notes at the bottom are critical and need to be delineated and itemized out so that everybody knows what you're authorizing. Why is it there's a question that says, why is it necessary to get quotes from providers if the waiver rates for the items are already set? That's true if the support coordinator actually has the correct service code with the item that reflects the correct rate, then we just need documentation that maybe the individual is truly incontinent or something like that. But it's the other items that are not specified on the rate table or that are lumped together under personal care items that we require the quotes for. Okay, there's a question that says, can you please review accurate example when a person needs over 200 units of diapers and pull-ups and how we shall submit if needs to increase to 280 units, for example? Would you put 200 under one code and 80 under another? So so Bob went over the criteria for requesting an excess over what the rate table allows. So if you provide that documentation and it is determined medically necessary, you can put the 200 units under that specific code for the rate table, and you can put the excess under the personal care items code. And just like, Sabah gave that example, just identify exactly what you're asking for, how many units and the cost.
Okay, the question earlier was the DME assessment and prescription. Who does the assessment? It depends on what the DME item is. It could be a physical therapist, occupational therapist, the physician. It all depends on what the item is. It's not an assessment that's done by the medical case manager in the region. It's done by a licensed person. But again, it depends on what the item is. And information regarding that can be found in the handbook.
We have a question about someone's asking how we'll pay for insure for individuals who have problems swallowing food. So supplements, according to our handbook, require a prescription and a dietary assessment. And if you provide that information and it's determined medically necessary, then the waiver can provide that.
Okay, there's a question about a method on how to find a Medicaid provider for consumable medical supplies and DME supplies. So ACA enrolls providers, and they enroll them and give them a certain authorization to be a certain type of provider. So there's a possibility that they could run a query to tell you who is enrolled to be that type of provider, but it still would not tell you if they provide these supplies. You would have to still contact the individual provider to find out if they actually do this. Just because it's a part of their enrollment does not mean that they will provide it.
We have a question from an individual who just inherited a consumer on the CDC Plus program, who is aged out of Medicaid, and that the parent was told by Medicaid that Medicaid no longer pays for the formula, which is costly, and he's also aged out of TRICARE. The question is, did I understand you to say that Medicaid will cover his formula once they are aged out? So if the individual, I don't know if we have enough information necessarily, if the individual is 100% fed via G-tube, then Medicaid does continue to cover the formula, but it may have to be requested through an exception process to EQ Health, and would be they would use the is it the A9900 exception code to make that request.
Right.
So the provider just needs to register through EQ Health as a provider for that service, and they can make the request through EQ Health for an exception.
And just to clarify with regard to Medicaid, if an individual is on fee-for-service Medicaid, they still go through EQ Health Solutions for their prior service. If they are on a managed care plan, of which we do have individuals who are, then they go through the plan. So that's just a clarification. Okay, we have a question: who usually pays for a replacement mattress? The individual has a hospital bed, mattress runs out and wants an air mattress. Generally, Medicaid covers hospital beds, mattresses, and the air mattress, but they do have criteria in terms of limitations to how many years before you can get a new mattress. So we'd have to know a little bit more about that one in order to give you a definitive answer.
We have a question. Does Medicaid state plan or waiver pay for ventilator or sleep apnea supplies, including oxygen concentrator? Medicaid, not waiver, pays for those items.
So we have a question that says, what is a G-tube extension? So G-tube is a gastrostomy tube where the individual has a tube where they're fed through their stomach. They could have an actual tube, or they could have what we call a Mickey button. The G-tube extension is a small piece of tubing. I'm not sure, I don't think it's more than 12 inches. And it connects to generally the Mickey button, which is skin level, and it then connects to the feeding bag.
We have a question that says, is it possible to have several funding streams for various durable medical or consumable medical items? For example, maybe natural support pays for some items, Medicare may pay for some items, Medicaid may pay for some items, and the waiver may. And yes, that is possible. And we encourage the other funding sources as well. We have a question, is a letter of medical necessity needed every year for the same supply, or is one sufficient to initiate the service? If you're submitting a request for additional information or SAN request, significant additional needs request, or you're requesting some kind of changes in the individual's cost plan, then every single time that is reviewed, it's considered a whole plan review, and so we still need to determine medical necessity each time that that's reviewed. We have a question that says, can two providers have an authorization for one patient in the same month, but for different items? And yes, they can. We have a question, who pays for a home use blood pressure cup for a consumer with hypertension? The waiver does not cover that blood pressure machine.
Okay, so at this point, we have reviewed most of the questions that have come in. If there was something that you submitted that you needed a little bit more information on or wanted to discuss further, you are welcome to send those questions to me, Elizabeth, and I will get them to the appropriate person. And then you can have that conversation with that person.